Good evening, students. Doctors. Good evening again. So, welcome to our 90-day University Prof Pre-Final Mastery Microbiology. So, today our class we completed Immunology 1 and now we are in Immunology 2. So, in Immunology 2, the topic is Immunology 2. So, you know what we're going to do here. Already you know that we're going to have a rapid revision of all important questions. The volatile fact, quick revision you will have, and then high yield topics of all subjects and most expected topics of each exam. For exam, it will be discussed. So it's for not only prof exam, but also for your next exam, NEET exam, FMJ, for everything, because the questions are taken, the answers are prepared in that way that it will be beneficial for all the things. Okay. So now, what is our next one? This is the thing. Today, what we are going to discuss is these are the questions we're going to talk today. So you know what are this? So first thing is going to be in long question, it's going to be an antigen-antibody reaction. That is basically agglutination, precipitation, those reactions. Okay, so definitely you can expect one question from there. You're going to talk about it. And then also immunodeficiency disorder, you know, that's the in immunology, that's one big topic. Immunodeficiency disorder is the disease-related topic, and you will expect a question from there also. In short essay, of course, agglutination, commonly expected question. ELISA, another commonly expected question, though more practical they ask, but you never know. Immunofluorescence 2 and complement pathways, a definite either short or long question, definitely will have complement. There was not a, almost every alternate year, they are asking this question, complement question. So you would be knowing about that, and cytokines and their functions, and MHC, definite short note expected questions. Okay, the questions are made in that way that is going to be very, very important questions are only taken chosen here. So Auricle, you know where to choose. We have all recorded classes, live classes, practical session, exam module, and hard copy sets. Or here in our in Auricle, you can find all these things here. And then of course, recorded classes is going to be very beneficial for you. As I told, flexible learning, expert instruction, convenient revision. And live classes, which we're doing now, you will get an in-depth coverage, and then you'll get an experienced educator for all subjects. Interactive learning will be there, and also express exam module will be there, will guide. And then one-to-one doubts clearing session, special session for the special whoever is going to assign for this program, they will get a special attention. All your doubts should be cleared directly, person to person. Okay. Then next is your hard copy sets, you know about that, and practical sessions will be soon taught. All the practically important things will be shown. The subscription plan, you have a foundation, advanced learning, complete learning, and ultimate MBBS plan. Choose whatever is beneficial for you and get all the benefits. For a discount, you can use this code, Dr. Santhosh Rajan 20, my name, and you'll get discount. And now, yes, we'll start a topic. Today's topic is a little bit more, so we will start it immediately. So, first of all, what is the question? You can see, enumerate the antigen-antibody reaction, first thing, okay? And then describe the principal methodology, clinical application of agglutination reaction. They just agglutination reaction with the examples they have mentioned, okay? Now, first of all, we're going to talk about the antigen-antibody interaction. Antigen-antibody in reactions, antigen-antibody reactions. So what are the antigen-antibody reactions we have? So before going to antigen-antibody reaction, little bit you should know, that is, when an antigen-antibody interacting, you should know what happened. The antigen epitope, you know that the epitope of the antigen, it's going to interact with the paratope of antibody. And then we have the reaction takes place, right? That is first thing, antigen-antibody reaction. The two terms are important, which can be asked in a 1-mark questions also. That is your affinity, and other one is your avidity. Affinity and avidity. Okay, affinity, avidity. What is this affinity, avidity means? Affinity means, when you talk about affinity, it is basically the all non-covalent interactions. Non-covalent interactions between single epitope and paratope, between single epitope and paratope. You're talking about the single interaction of epitope-paratope interaction. But avidity means again same non-covalent interaction of all, all the epitope and paratope. All the epitope and paratope of antigen and antibody is going to happen. Okay. That is it gives the overall strength. It gives the overall strength It gives the overall strength of antigen-antibody interactions determined by avidity. That's also a question. Okay. If you're talking about only single affinity, you're talking about all the epitope and paratope interaction, that is overall strength, that is your avidity. That's all. Okay. Now, when you talk about antigen, the next one definitely which you are going to write is something called Marak's hypothesis. You call as Marak's hypothesis. Marak's lattice hypothesis. Yeah, Marak's, you call this Marak lattice hypothesis. Nothing. It's very simple one. Basically, what happened in Marak's hypothesis, it's like this. You draw a graph like this. We have three zones. Okay, three zones. So what are the three zones? One is your pro zone. Okay, and post zone. And this is zone of equivalence. Okay. So pro zone, zone of equivalence, and post zone. Okay, it's a post zone. Okay. Now, what you can see is that here in Marak's hypothesis, in pro zone, the number of antibody is high. You have so much of antibody in pro zone than antigen. In post zone, you will have antigen very high. Antigen will be very high. In zone of equivalence, your antigen will be equal to antibody. Total number of antigen will be equal to antibody. So what happened? This is exactly, so you get a correct result. Your result will be, when you're doing an antibody, the result will be proper. Correct result. In other two cases, what happened? Antigen antibody. So this phase is the correct phase. In other phase, if antigen or antibody is high, there is increased chance of false positive or false negative results. That is the thing. So you have to get a proper agglutination reaction or proper interaction, antigen-antibody interaction, agglutination or precipitation, both are okay. Precipitation, you have to have an equal amount of antigen and antibody. That's it. This is the Marak's hypothesis. Okay. Now, they asked about agglutination reactions only. Okay. So precipitation reaction we already spoke in the last class. Now we are going to the agglutination. So Marak's hypothesis you are going to read. Then that's it. Now about the agglutination reactions and application. So agglutination reaction. First, the definition is very, very important. Here, what you're going to say is that you're going to write here insoluble. In precipitation, it was soluble. Here it is the insoluble antigen combines with the antibody in a presence of proper pH, NaCl, and temperature. Okay, temperature. You get what? You get when there's agglutination, you get a clumps of formed. Clumps, that is the agglutination. Clumps are formed, that is the agglutination. Okay, insoluble antigen antibody combination that leads to formation of the clumps. That's it. Okay, so before that agglutination stopped, we haven't enumerated the antigen antibody reactions. Okay, so let's stop with agglutination definition. Now we are going to write all the antigen antibody reactions first, then we have to come. Okay, antigen antibody reactions. So we classify them as two. One is the conventional, the old ones. Other one is the newer methods. New methods, the advanced, latest ones. Okay. In conventional, still most of them are used. At least what are used? One is your agglutination. Agglutination. Other one is your precipitation. Precipitation. Agglutination, precipitation. Third one is your, which one? Neutralization. Complement fixation. Though they have decreased, but still agglutination and precipitation all are important for many tests. Okay. In newer methods, if you see, they are example like your ELISA. Number one is ELISA. And then you have radio immunoassay, RIA, radio immunoassay methods. Okay. And you have fluorescence. Fluorescence antibody assays we can use, different type of fluorescence. And we also have chemiluminescence. Chemiluminescence. Okay. And a lot of rapid methods, rapid Carter's rapid methods. Okay. So these are the newer methods we have. But for us, the question asked was agglutination. They asked clinical application and the methodology and use and examples. Okay. Now we talk agglutination definition we have told. Now, what are the examples and uses? Okay. Example and uses. examples and uses of some agglutination reactions. Okay. So what are they? When you write the list, number one, you always start with the common ones, right? So common one, if you talk, let's talk about the first one, Vidal test. Vidal test. Other one is next all. After Vidal, a list of the test like CAT test, that is your cold agglutination. Cold agglutination test. Then we have MAT test, that is your microscopic agglutination test. And we have one more SAT, standard agglutination test. You see everywhere this word is coming, right? Agglutination. Okay, these all are some important, especially it's a tube agglutination. The all we are talking here is a tube agglutination tests. Okay, and next is your wheel Felix. Then Paul Bunnell. Also Combs test. These are some important tests for detecting what are the diseases. They told application of these things with examples. So now how we are doing these Vidal test, you know, it is for your typhoid fever. CAT test is for your cold agglutination for your mycoplasma. Microscopic agglutination you will do for leptospirosis. Okay, and standard is for SAT test is for brucella. Wheelflix is for rickettsia. Paul Bunner is for Epstein-Barr virus. Coombs test is for RH grouping, RH blood grouping. Okay, you can use it. Okay. So these are the things you are using common examples and principles of the methodologies, principal methodology. Basically, for everywhere, what you're doing is you're using an antigen antibody and then seeing for a clumps. That's it. Reaction would be clump is there or not. Some you're titering, some no titer. That's all. Okay. So these are the example use of agglutination. It's more than enough, sufficient. Okay. Yes. So we're done with this question. Now, next. So here you can see all the explanations are also given here. You can go through this. So given antigen antibody, Marak's lattice hypothesis, agglutination types and the examples. Okay. Now, immunodeficiency disorder is another very, very important disorder. You know this one. An immunodeficiency disorder, excuse me. Yeah. So now in immunodeficiency disorder, excuse me. So I'm going to write it here. In immunodeficiency disorder, what other things are coming? So you can classify them into different. What are they? The immunodeficiency disorder can be phagocytosis defect, number one, or it can be B cell, can be T cell, or combined combined deficiency. Okay. So these are the immunodeficiency disorders. Because in immunodeficiency disorder, what happens is that your immune system immunity goes down. So you have increased infections. Increased infections can occur. Okay. So now the question is describe briefly various T and B cell related disorders. That's the one you do. So when you talk about phagocytosis disorder, the list is like this is your chronic granulomatous disease. Not going in detail here, they haven't asked about it. Chronic granulomatous disease, basically NADPH deficiency, and Chidiac Higashi syndrome. Chidiac syndrome, where there's a phagolysosome defect. So those are example of phagocytosis defect. Now talk about the B cell disorder. We're going to talk now. Bruton's list is Bruton's A gamma globulinemia. Okay, and there is a variable immunodeficiency, combined variable immunodeficiency, and there is the IgA deficiency, and then hyper. Then there is hyper IgE also, hyper IgE disorder. Okay. These are all the things in B cell, important. T cell, when we talk about the T cell, what are the important in T cell? In T cell, the list is like, most important, DiGeorge syndrome. You have to always write about DiGeorge syndrome. People, they like it. And there are other syndrome like Nude and Job syndrome. Nude Job and Nude syndrome, Job syndrome, DiGeorge syndrome also. Okay. We're talking about everything now. And mucocutaneous candidiasis. When T cells cool down, candidiasis automatically comes. Okay, that's what. Combined. In combined, Wiskott-Ulrich. Wiskott-Ulrich syndrome, number one. Okay, Wiskott-Ulrich, number one. And what else? Severe combined immunodeficiency. Severe combined immunodeficiency and ataxia telangiectasia. Ataxia telangiectasia. So at least two diseases you have to mention. Example, we talk about immunodeficiency disorder. Now we individually T cell and B cell we're going to talk. So first let's talk about the B cell. Okay. So this is the thing. Now we're going to the B cells. So we'll go to the start with the B cell and then we'll go to the T cell. Now, first one, B cells disorder. In B cell, first one, as we told, Bruton's A gamma globulinemia. Number one, we will write it here itself, everything. And other one is your it's a common variable immunodeficiency. Third is your IgA deficiency. The last one is your Ig hyper. Okay, this is called hyper IgM syndrome. Just like the name says, this is the easy ones. Okay, it's very easy. It's only a little bit you have to accept the concept. When the B cell means itself, generally what we're talking about the immunoglobulins, that is antibodies. So now what happened in Bruton's A gamma globulinemia? There is this B cell tyrosine kinase defect. So what happened? Your pre-B cell is not converted to pro-B cell. So basically what happened? Your B cell is less means then automatically the plasma cells also will be less. So your immunoglobulins also will go down. There will be decreased immunoglobulin. Okay. So these child, so B for B cell, B for all B cell defect, B cell goes down. So B for babies. So babies usually what happen, more than 6-month babies, usually they are highly prone to get different type of infections. They can get usually enterovirus, Giardia. Whenever immunoglobulins go down, these are the infections common, and even lot of pneumonias also because of sinopulmonary defect and all pneumonias they can get more than 6 months. Okay, this is important thing. These are the common clinical features, but also these children they don't have what they have no tonsil. You don't see tonsil, no pear patch. These things also will be absent. That is what. Okay, so A gamma globulin means no immunoglobulin. The idea is no immunoglobulin. That's what you have all this defect. Bruton A gamma globulinemia. Common variable. Common variable, one thing very interesting. A B cell is normal. B cell is normal, but there is no, which one? No plasma cell. There is no conversion into plasma cell. They are very low. And because of this, what happened? Usually the immunoglobulin goes less. But the only thing is that in common variable, it is usually it happens to the adult more than 20 years only. The patient get lot of infections, immunoglobulin deficient infections. That's it in common variable. So variable means B cell is normal and no plasma cell. That's what it's variable. Okay. In IgA deficiency, if you want to know, this is the overall most common immunodeficiency disorder. Most common immunodeficiency disorder. When IgA is low means itself, you have to remember there is increased chance of sinopulmonary infection first. because Ig is in the mucosa secretion. So if that goes down, so you get cyanopulmonary infections, number one, and other giardia is very common, and other enterovirus infections also, enterovirus. So common infections you get. So here what happened? IgA would be low. IgA will go low. That's it. In case of hyper IgM syndrome, this is very particular. Here what happens is that we have this CD40 defect. CD40 is basically for class switching we needed. For class switching we needed. So when that is defect, what happened? IgM is not converted into other immunoglobulin. So IgM only increases, rest all immunoglobulin, rest all goes down. That's what it's just hyper IgM. So again, same, the symptoms would be same symptoms, the infections, because rest of the immunoglobulin low. So you get the similar infections will be there. That's all. This is about your B cell defect. Now we are going to the T cell. In T cell defect, as we told, we already spoke about the list we already told. So what are those lists? T cell, if you see, D George. The first disease we are going to talk here is very important one is D George syndrome. D George syndrome itself is like you'll get full mark if you write almost major mark they will give you. Okay. And then uh, mucocutaneous candidiasis is another in T cell defect you can have. And other one is two important syndrome, nude, not that common, but then yeah, just for nude and job syndrome. Job syndromes. Okay, they are not that much. The most important in T cell is your DiGeorge and mucocutaneous candidiasis only. This one examiners will expect you to write. In DiGeorge syndrome, the shortcut it is simply called CATCH, catch 22. You have to write just catch 22. That is the clue. C for, first of all, here the C stands for cleft palate. Cleft palate or lips. Okay. A for abnormal face. T for you know that is your T for main thing, that is your thymus dysplasia. So thymus gland is gone. That is what all the infection, because of thymus dysplasia only, there is increased infection, increased candida, increased many infections, but mainly increased candida infections occur. C for cardiac defect. Cardiac defect, which is the most common feature, tetralogy of Fallot, TOF, tetralogy of Fallot, you can see. H for, again, hypo-PTH, your parathyroid hormone goes down. So your calcium also goes down. So the patient ends up in getting tetany. Okay. 22, because the involved chromosome is chromosome number 22, small q 11. This is exactly. Everything is a 1 mark question or a short notes, can be a simply DiGeorge syndrome. If you know catch 22, easy. George catches. George catches 22 balls. Remember like that. Mucocutaneous, basically cutaneous infections. So you can have any infections. When you talk mucocutaneous, they can have oral candida or esophagus, can be of esophageal candidiasis, or vulvovaginal candidiasis, curdy white discharge. So these are all common in T cell defect. Any T cell defect, you expect these diseases. Nude syndrome is basically here these people have baldness, nail dystrophy. Nude means it's like everything is gone, no? Nail dystrophy, baldness, and of course, because of T cell defect, infections can happen. Job is one syndrome where you have IgE goes high, one hand, another hand T cell is defect. So here what happens is that here there is Job usually not only candida infection, apart with candida, he will be getting with staphylococcus, multiple staphylococcus abscess. Very, very common with the Job. That's it. Okay. DiGeorge, mucocutaneous, nude, and Job syndrome. These are the very common for T cells. Now, next, the last one, combined. In combined, yes, you have a lot of things, important things here. When you combined cell deficiency, that means both T and B, combined T and B deficiency. The first one here, the first disease is Westcott-Aldrich. Westcott-Aldrich is number one. Number two is this one, combined. I should once again severe, actually the full word is It's called as SCID, severe combined immunodeficiency itself is directly one question. The last one is, the third one is your ataxia telang egg. Telangiectasia. Okay. Telangiectasia. Telangiectasia. It's a big word. Okay, no worry. So Wiskott-Ulrich syndrome, severe combined Wiskott-Ulrich syndrome. Okay. So everything is easy. There's already clue for you. You don't have only the names, you have to remember, that's all. Wiskott is the gene name, it's a WASP gene defect. It's a WASP gene defect, number one. Okay. First one. Then what is important in this disease, in Wiskott-Ulrich syndrome, again, it is basically common. You have both a T and B cell defect will be there. One thing, WASP gene is the gene mainly involved here, goes down. So these patients, again, because of both the before that, both T cell defect is there, both T and B cell defect. Here, especially what happened, you see W, this IgM goes down. IgM is the one which goes down in Wiskott-Ulrich syndrome. Okay, that's all. With this patient has all similar, multiple infections can occur. Okay, multiple Wiskott-Ulrich cases, the multiple infections. The shortcut, wait, I will tell you to remember like this, it'll be more easier. The shortcut, you can remember, it's like water. Okay, I'm going to write it as a water. Okay, what do you mean by water? Here, WA is Wiskott-Ulrich. Wiskott-Ulrich. T for thrombocytopenia. Thrombocytopenia. Okay, T. E is basically, one second, thrombocytopenia. Yes. So, yes. So, next is your, another one is your, T lung, this is TE only. E, okay, E is fine. R, recurrent infection. You get recurrent infections. This much. Okay, very, very simple. So, yeah, E is also, you can write eczema. You can write eczema. Eczema, like allergic dermatitis, can happen. That's what. Okay. So, Wiskott-Ulrich, thrombocytopenia, recurrent infection, eczema. Water. Wiskott-Ulrich is water. Shortcut is water. Remember like this. That's all. Very simple. WASP gene. Okay. Now, severe combined immunodeficiency. Severe combined immunodeficiency. Here, what happened? It will be very severe. The disease. So, the most common, if you remember, adenosine deaminase deficiency 1. This one, but also this PNP protein, purine nucleotide protein defect also will be there. Because of this only, what happened? Patient will have multiple infections, multiple different type of infections happen in a combined immunodeficiency disorder. That's very, very important. This is, and if you remember, this is the for treatment. It's the first place where gene therapy was used. Gene therapy was successful. Gene therapy, otherwise bone marrow transplant, or for the transplant. Only for this I'm stressing, because in severe combined immunodeficiency, this has helped. Gene therapy immunity. Okay, that's all. And telangiectasia, very, very simple. Nothing here. Here, one thing is that IgA and Ig telangiectasia E, no. So A and E goes down here. The patient have ataxia, number one, plus it has telangiectasia is basically skin rash. Telangiectasia is basically, it is a spider. They are also called a spidery angioma. Okay, spidery angioma, which is very characteristic, plus lot of sinopulmonary infections. That's it. This is a good, it's a little bit complicated and more, but one or two revisions if you do, it will come automatically. You don't need to worry. Okay, that's all. This is for the telangiectasia. Now, next. So long questions over. Now we are going to the short questions. Okay. Now we talk short questions. Yes, everything is explained here. You can go through these slides. Okay. All TB, telangiectasia, everything is mentioned. Severe combined, etc., etc. Okay. Agglutination mentioned, the agglutination test and precipitation. We already told in the first question. So I'm going to skip that part. ELISA. ELISA again. When you talk about the ELISA, It is basically, the enzyme linked immunosorbent assay. So here, basically, we are using an enzyme that coats with the antigen and antibody, and we're seeing the color changes. Okay. So this is the method. So this is basically again, it is basically we are using a microtator plate. 96 well. Now microtator plate with 90, you have a big microtator plate. So 96 wells will be there. Okay, like this wells. So there you're titering to check the reaction. So you're adding the antigen. It depends on what are you going to do, antigen or antibody accordingly there. So different types are there. So if you talk about the types, we have so many types here. Direct, we have direct, indirect, sandwich, direct, indirect, and then combined. Okay, these are the different types of ELISAs, direct, indirect. So here what we're doing, the one important thing you should know is it detects what it's detecting and what we are using. Okay, that is the most important thing. Rest all you can write it generally. Okay, so detecting part is the direct detects the antigen. Indirect the antigen or antibody, we don't know. Sandwich also detects only the antigen, but combined again, it can detect antigen or antibody because it's combined, right? So for detecting this antigen, what type of antibody we have to use? We have to use a primary antibody. For indirect, we are using the secondary antibody, anti-human antibody. Okay. Again, for sandwich, we are using primary antibody. It depends again, direct or indirect. It can change. Okay, primary or secondary antibody. Yes. And for combined, again, we're using secondary antibody. Okay, this is the clue. So now if you see here, same thing, you can see here, we have taking. So it's a more sensitive and ELISA, yes, very important thing is it is used to sensitive and it's used for screening in blood banks and tertiary. Any first test you're detecting, it has to be ELISA only, especially serological test for viruses, it should be ELISA. ELISA is very common one. So this is the way how it goes. You see, everything's mentioned. Oh, that's the third one, with the first direct, indirect, sandwich. Combined is actually competitive. Some place they say combined, but you can say competitive also is better term to use competitive. And ELISpot also. Okay, ELISpot basically you using the cell producing antibody. That's all, nothing else. So this is the way of described. Okay, that's all. And this basically you see the technique, this picture you given here. Let's say you want to detect the antibody. So you already have you want to detect some. Let's you want to detect the dengue antibody, dengue virus antibody. So already what happened in the well, you have a coated target protein is there. That's what you want. Let's say NS1 antigen you are detecting. You want to detect the NS1 antigen of dengue. So then you're adding the antibody. This is your primary antibody you're adding. So what is that? You see, you added the antibody and then you're adding the target protein. Antibody is added. Okay, reaction is happening. Okay, now you're also adding an enzyme labeled antibody. The primary or secondary antibody depends on which one. Okay, adding. And then what happened? There will be a reaction happening. And then what happened? Automatically you see the color change. These are the color changes happening, no color change. So that means they are positive. That you have to put into the reader and check the OD values and interpret. That's it. Okay. So that's what it's very sensitive and screening test in all the blood and you can just write this thing more than enough. Okay. In immunology. Now, what about next one? Immunofluorescence. Immunofluorescence, I'll say here, the name itself says fluorescence. So what you do is that, let me go to the picture here better. So immunofluorescence itself, it's the same like, immunofluorescence is same like your ELISA only. Only thing is you're using a fluorescent dye you're using. You can see here, this primary antibody, this is in direct or indirect, primary antibody, secondary antibody. So you see, you're coating it with the fluorescent substance. That's it. You're coating it with the fluorescent substance. That is the main thing here, nothing else. Okay. So it can be a direct immunofluorescence or indirect, or we can use for flow cytometry also. So indirect, always remember, direct means it's about antigen, direct immunofluorescence, any direct ELISA, direct immunofluorescence, direct agglutination, everything is antigen detection. Indirect is always antibody, indirect antibody. Okay, that's all. Then flow cytometry. Flow cytometry, very important role is to detect the CD4 cells. You know, if you remember in HIV, to know the prognosis, we used to check the CD4 count, CD4 count. Though now it's, if you're doing PCR to check the copies, number of copies, but still CD4 count was very much used in HIV to detect the severity and prognosis. So CD4 count, to detect that, we are using that. They are also using this fluorescent substance, flow cytometry. That's all. Okay. So example, if you, they ask you to give some example, direct immunofluorescent, very important in rabies. You remember rabies, that was a gold standard test to detect the rabies antigen, to detect the antigen you're detecting by direct immunofluorescent assay you're doing. Indirect immunofluorescence, many example, if you remember, FTA ABS, FTA fluorescent troponemal antibody, which we are doing in syphilis, where fluorescent is used. Okay, so that's what, these are the immunofluorescence, very commonly used. One is you're using direct, and also plague also, that's okay, fine. But here, if you remember this, it's enough. Direct killer rabies, indirect killer FTA ABS, it's syphilis. That's all. This much only for your immunofluorescent test. Okay. Now, next. Next is the define the complement, and they asked to describe the classical complement pathway and mention the biological function complement. Okay, it's very simple, easy. Okay, now when you talk about a complement, complement are the proteins which occupy 5% of plasma protein, 5% of plasma, okay, produced in the, they are usually produced in liver, mostly in liver, followed by spleen. They have role in inflammation. They have very important role in inflammation. So we are going to talk about that, all things in detail now. So we have basically three types of pathway, three types of complement pathway. This you must write. Yeah, very important. One more question also. Classic pathway, and then you have alternate pathway, and then you have Mannose binding. Mannose binding pathway. Okay, classic, alternate, Mannose binding pathway. Now, here what we're going to do in classic pathway, you know that we're going to talk each one. Okay, let briefly to say each one. Classic pathway, it's usually it is started by IgG or IgM, stimulated by, okay, IgG and IgM, stimulated by, it is all pathway. This is stimulated by IgM. A for alternate. So it is IgA, usually IgA, but of course some lipopolysaccharide also can do, not a problem. Here it is Mannose, so Mannose. Mannose from the cell, in the bacterial cell wall, Mannose present. Okay, that is binding protein. This is stimulated by. The first complement which is activated in classic is always your, that's a question. First is classic, so it is always C1. Alternate pathway, it is C3. Okay, C3. C3A, but okay. C3, if you remember also, it's fine. Yes. Okay. And Mannose, MANN. No, so it's C4. Remember this much only. Okay. So now classic pathway comes under which immunity? This comes under the acquired immunity, acquired or adaptive immunity, right? Immunity. Whereas alternate and Mannose, if you remember, they come under innate immunity. We spoke about it, innate immunity. That's all. Okay, this is the basic thing you should write. Now they asked about classic complement and its function. So that's very easy. So if you want to go to classic pathway, classic complement. See, even it doesn't matter. I'll go with alternate also and Mannose also. They are very small, nothing very big, fancy here. Mannose binding pathway. In three pathways, you should know the beginners. That means you should know the first one. So C1 here. Here it was C3 only. Mannose, it was C4. Now the next one would be here C4 and C2. C3, C3 only, same only. It just becomes a C3A. Okay. Then Mannose binding C4. The next would be C2. Okay. Now what happened? all these three things will go and activating what? They will form C3A only, active form. From C3A, the next activator would be C5. And from C5, the next one would be the complex, C5 to C9. I'm writing in a very brief way. You don't need to remember everything. Complex. Okay, this is the pathway. So this is basically you're remembering these things. C1 complement activate, C4 complement C2, and then C3A is activated, then C5, then C5 active, C5 is 6. This is a membrane attack complex. This you have written. Now, after writing this, you're going to each function. So complement is formed. Now, how it is performing in our body. So that one, the functions. That means you're going to talk about the functions. Functions of complement, each has individual function. Very important. One more question. So you write here C3A separately. And then you have C3A, 4A, 5A. All together they have some function. C5A has some function. And you have C5 to 9 complex has some function. Okay. Now, what is the C3A? C3A be both the same. They usually cause opsonization, phagocytosis. So basically, complement helps in the phagocyte. They assist in the different type of causing the phagocytosis. Basically, okay, it helps in the phagocytosis. One. See, all the A, they are causing anaphylaxis. Okay, and 5 causes chemo. We call chemotaxis or chemoattractant. Okay, C5 to C9, what is they cause membrane lysis? They cause membrane lysis of bacteria. That's all. These are the function, basic function you're going to write. Okay, overall they help in assisting the inflammation in our body. That's all. Okay, this is the thing. This is the basic function of this thing. So now you have all the things described here also. You can go through the thing. Okay, sorry. Yeah, it should be here. No, sorry, I wrote it in previous question. So everything is written: heat level, classic pathway, alternate pathway, and then you see the functions of classical alternate mannose and everything. What function, what is it as? Everything is mentioned here. Now, and then cytokines. Cytokines are another important. I'm not going to individual. If I go, we have to see the time also. So one second. Yeah, okay. Let me try to go it fast. So interleukins, we have a lot of interleukins. Cytokines, you have different cytokines, their function. So in interleukin, we have interleukin 1, 2, 3, 4, 5, 6, 7, 8. 9 is not important. We're not doing 9, 11, 12, 13. Okay, interleukins. And then we have, if you remember, interferons. And we have interferon alpha, beta, and gamma. Alpha, beta, gamma, right? Interferon alpha, beta, gamma. And then TNF alpha factor. These are the things. Now each one has some individual role. So that only. See, one is one always for fever. One is for fever. I'm going to take very briefly the explanation given. Most important thing you should remember. First for first fever. 2 T cell. T for 2. So two cell proliferation. M is myeloid proliferation. Myeloid cell, that is for your B cells and all, no? Myeloid, lymphoid and not the neutrophil, eosinophil, RB, the other things, those myeloid proliferations. Okay. And 4 basically, it is causing class switching between G and E, class switching. Okay, class switching. Okay. 5, the shortcuts are given in the main notes. You can check because I'm not going to talk about shortcut, that will take so much time. Okay, so this is IgA and eosinophil. 5 is for IgA activation and eosinophil attraction. Eosinophil attraction we needed. 6 is basically again 6 also not it's similar to interleukin 1 and cytokine storm. If you remember, cytokine storm, storm is caused by 6. 7 is again 7 lymphoid proliferation. It helps in the lymphoid proliferation. Okay. 8 is basically chemotaxis. Okay. 10, it decreases the inflammation. Somehow it acts on different medium, decreases the inflammation. One good thing. Okay. And 11 for platelet activation. 12 is for it causing the T helper 1 and natural killer cell activation. This is very much similar to interleukin 4 like action. That's all. Okay, this much is enough. More than enough. Okay. Now interferon alpha beta gamma. See, alpha, it is produced from the macrophage. Beta is coming from fibroblast. This is coming from T cell and natural killer cell. These two has one property, antiviral property. Antiviral property. Okay. Whereas your gamma has anti-tumor activity. Anti-tumor activity. This much. More than enough. Okay. Now what about the TNF alpha? TNF itself says it's a tumor necrosis factor. These are all interferons, interleukins. Tumor necrosis factor. Dangerous one. The name is of danger. So it is very important role in causing sepsis. Number one. Number two, it causes a tumor. It even causes a tumor necrosis. Kills the tumor. Sort of good. Okay. It kills the tumor necrosis and lyses it. And it causes lot of lipolysis. So it is very much similar to interleukin 1 and 6 action. You can say. That's all. These are the important cytokines and the function I've told you very briefly, but you have our beautiful slides made here. You can go through all the slides. Here it is. Everything is given. You can go through. Okay. Tumor episodes, etc. And then there's also. You can go through the some uses. Yeah. Interferon beta, multiple sclerosis, gamma for chronic relevant disease, and alpha for different type of viral infections. Okay. That's all. Now we're going to come to the last question. Last is MHC. MHC is basically major histocompatibility. Or I'm going to write it now. So this is basically called major histocompatibility, otherwise also called HLE, human leukocyte antigen. That is HLA. Okay. MHC restriction or HLA. Now, what are the things? So we have three things. We have here three of them. What are three? MHC 1, 2, and 3. So what are the differences? First of all, they all are present in which chromosome? They all are located in chromosome number 6. Chromosome number 6, short arm. Okay, short arm. But the locus is in 6 is different. 1 is present on the locus A, B, and C. 2 is present on the locus. This is present on DP, DQ, DR. 3 is present on the locus called HSP C234 compound. That's it. This much. 234. This is the compound. It's present here. Now, that's fine. Now, what about the individual function? So, MHC1 and MHC2 is the most important one. This is usually MHC1 is present on, they basically MHC, what they do, they usually present the antigen. That's all. They usually present the antigen to antigen presenting cell. That's all. Okay. So now onto the T cell activation and other things. Okay. So now MHC1, if you talk, this is present in the all nucleated cells. All nucleated cell except, that's a question, one more question, except RBC and sperms. We don't have it in these two. It's not present in RBC and it's present in all APC cells. Okay, antigen presenting, I'm going to write APC cells, antigen presenting cells. And also it's present in platelet. Platelet is non-nucleated only, but it's present platelet also, it's present. Okay. MHC2 is present only in the antigen presenting cell. That's all. That means your B cell, dendritic cell, and also macrophage. That's all. This three only. Now, MHC1, it is processing it's presenting the antigens to which cell? CD8. But MHC2 present to CD4. Okay. Or 1 is to 8 is equal to 8. Or you can write 4 is to 2 is equal to 8. Same way. That's all. Next point is they present all the intracellular antigens. Intracellular antigen means viruses. Example. Here it's presenting all the extracellular antigens. All your bacteria, and all those things come in extracellular. Right, okay. CD, intracellular, extracellular. So this pathway here involved is called cytosolic pathway. But this is endocytic pathway. More than enough. If you write all this point easily, you'll get your 5 mark very easily. That's all, this much only. MHC or HLA, human leukocyte antigen. Okay. So we are done with this also. So this is your immunology class 2. So you can see, you can go through these notes also here. All the notes are given. What are things processed? How? Yeah, the groove. You have to remember the where the site. Here is alpha 1, alpha 2. Here it is alpha 1, beta 1 groove. That is important. And everything we have spoke here very clearly. Okay, that's all. So we're done for today. So thank you so much. We'll continue with the other classes in the upcoming thing. And so now we have to say bye. Excuse me.